thank the organisers for inviting me to give this keynote lecture in the SARP Asia Congress this year. I'm going to speak about integrating biology into current clinical practice in childhood cancer. My name's Pritchard Jones, Professor of Paediatric Oncology at University College London, and I'm the current president of SIOP. I have no disclosures, and I'd like to overview in this short half an hour a few aspects of biology in childhood cancer, what it's told us about etiology, then some examples of clinical applications of prognostic and predictive biomarkers, and then to move on to the need for new approaches to clinical trial design and geography, so who's taking part in clinical research, and the need for a new paradigm for paediatric oncology drug development. So etiology, we've known for many decades that predisposition to childhood cancer can be inherited. And here's the classic Knudsen two-hit hypothesis. And the early so-called tumor suppressor genes to be identified from the 1980s onwards, retinoblastoma, Wilms tumor, P53, provided excellent knowledge for a very small proportion of children. And this worked well when the cancer penetrance was high, but it's been more problematic when the cancer phenotype's very variable. And I just want to give you an example. So children with the overgrowth syndrome, either the full spectrum of Beckwith Wiedemann or just isolated unilateral hemihypertrophy, are known to be at increased risk of Wilms tumor. And traditionally, they're put on 3 monthly ultrasound screening, which needs to go on for the first 7 years of their life. But this is very arduous for families, and also does everybody with this phenotype need screening. So in the last few years, experts in genetics and biology from around the world came together to produce an international consensus statement that was published a couple of years ago. And they brought together genomic data on the underlying genotypes of children with Beckwith Wiedemann syndrome, which is a very complicated disease due to multiple imprinted genes and control regions. And they've shown that through the analysis of the methylation patterns around the insulin-like growth factor 2 and H19 genes, and then this other IC2 locus here, they could subclassify Beckwith Wiedemann syndrome and hemihypertrophy risk of Wilms tumor according to the underlying genotype. And in fact, this international consensus statement now recommends that children where there's only loss of methylation at imprinting control center 2 here, which is distant from IGF2 and H19 over here, should not have surveillance because their risk of Wilms tumor is so low. The other aspect of etiology is understanding how embryonal cancers of childhood are effectively normal development gone wrong. And we've for long known that the theory is that the sources of mutations in childhood tend to be sporadic, stochastic mutations in genes that normally control normal development. Whereas in adult cancer, most cancer is driven by mutagen exposure. That means the timeframes for oncogenesis in childhood are much shorter, starting with the fertilized egg. And there's a very nice article published just at the beginning of this year that describes these models and how we can view cancer development in children as a maturation block in normal development. And single cell analyses may reveal novel therapeutic opportunities, potentially maturation therapies, and even possibly preventative therapies for those at increased risk. We also know from the extensive genomic sequencing that's been carried out on cancers across all age ranges that childhood cancer has a much lower mutational burden than adult cancer. And notice here, this is a log scale of the mutations per megabase of DNA. Over here, we've got adult cancers, and here we have childhood cancers. You do get some occasional cancers that have very high mutational burdens, but they're the exception in childhood cancer. And these genomic analyses have shown that up to 10% of children have pretty unambiguous germline predisposing mutations, and a further substantial proportion have gene sequence variations that suggest that it may explain their cancer. But more importantly, the somatic mutations are showing that about half of childhood cancers have potentially druggable gene targets. Now I want to move on to how we've applied biology in diagnosis and classification. And of course, the analysis of tens of thousands of genes has led to an explosion, literally, in diagnostic subcategories. And what we found is that molecular classification is being very rapidly adopted into diagnosis. And here's the example of medulloblastoma. And it's only back in 2012 that there was an international consensus on the fact that medulloblastoma could be molecularly classified into 4 subgroups. One typically in infants with a very good prognosis due to Wnt activation, one associated with desmoplastic pattern with sonic hedgehog gene mutations, and sorry, this is the infant one, and then 2 other groups, which are in fact the largest 2 groups, where there's no clear single genes involved, but a lot more genomic instability. And the recognition of these 2, especially the Wnt and the sonic hedgehog, by a variety of genomics and exclusion of gene amplification, has allowed selection of children for potential therapy reductions, because we know that if we can reduce radiotherapy in these groups, we may have equally effective treatment that's less toxic, and also highlights early identification of children where further treatment intensification may be needed. So it's only 4 years from 2012 to 2016 that the official WHO classification of tumours of the central nervous system brought in a major restructuring based on biology and defined new entities by histology and molecular features. But things didn't stand still. And then we now have a DNA methylation classifier based classification of CNS tumours, which was published in 2018, and which the WHO are in the process of considering adopting. But how does this all work in routine practice? And this was a nice paper published a couple of years ago, led by Tom Jacques, a specialist pediatric neuropathologist at Great Ormond Street, who took nearly 500 brain tumours seen in his routine practice over a 2-year period. And he requested the methylation array, which has been worked up by the Heidelberg group. And he was able to use it to successfully classify just half. So it doesn't work all the time in applying a classification. And it was estimated to change therapy in about 4%. But of course, this is in a service where there's already a specialist pediatric neuropathologist using state-of-the-art molecular FISH for copy number, gene sequencing, immunohistochemistry. He also went back and looked at a separate archive of nearly 200 cases of difficult to diagnose cases in the past. And by applying his up-to-date expertise and standard molecular pathology, he could reclassify half of them, and the methylation profile added another 17%. So it clearly has value, but there are challenges in introducing molecular biology into cancer diagnoses. As you saw in that previous one, tissue selection for DNA extraction is critical. You must ensure there's tumour cell DNA in the sample. So there will be failure rates for a variety of reasons, including the methodology. And the outcomes of these biomarker assessments need to be standardized and comparable across the world. And of course, they need to be affordable and achievable. But there's a much bigger clinical challenge, because there are literally hundreds, if not thousands, of molecular biomarkers that could be applied to an individual cancer. So which ones are important for which cancer types? How rigorous are the tests themselves in terms of sensitivity and specificity? And of course, one must understand the total treatment context to understand the outcome relevance for the child. So moving into clinical practice, if one's going to take a molecular biomarker and introduce it for treatment choice, then you have to consider the numbers needed. And this is a statistical table from an old paper. Standard approaches to introducing an intervention is if the prognosis is very poor, so the 5-year survivals of the order of 25%, you can look for quite large differences in event-free survival, and the total number of patients you need is achievable in a single disease category. But if you need to look at equivalence, so you want to use a biomarker perhaps for optimizing therapy, and you want to show that survival is already 90%, then you are literally going to need thousands of patients. And as each individual molecular entity is relatively rare, many of these numbers appear to be unachievable in childhood cancer clinical practice. Now, the potential for biomarkers is that we can improve our stratification of children, so we only give intensive treatments to those at highest risk of relapse, so we try and push their survival rates up. But of course, as we increase therapy, there's a concern that we reduce quality of life. And what we hope is that we can bend the curve, that targeted therapies will give us more accurate risk stratification, so a smaller proportion of a particular disease type will need the most intensive therapy up front, and that also targeted therapies may be more efficacious in their own rights and have fewer side effects. But some of these statements are, of course, hypotheses yet to be proven. So the current clinical applications of biomarkers in this context are for looking at dose reductions of conventional therapy in low-risk tumours, such as application of rapid early response, negative minimal residual disease in good risk ALL, intensification of therapy if a biomarker predicts a higher relapse rate. MYC amplification in neuroblastoma is a long established example. And of course, introduction of novel therapies targeted to the biological pathway that's disrupted if there's a high relapse rate on maximal conventional therapy. And the example I want to talk you through is imatinib in BCR-ABL positive childhood acute lymphoblastic leukemia. But I would just make the point that things like the introduction of MYC amplification to increase therapy in neuroblastoma has never really been tested in a randomized trial. It's more been an accurate definition of a poor risk group and then a leap of faith that increasing the intensity of therapy and ultimately targeting things towards the characteristics of MYC amplified neuroblastoma that will make the difference in outcomes to children. So coming back to these numbers, where are we with ALL? So this is another disease that's been splintered into many, many subgroups by molecular biology, which of course have helped with better stratification of children to different therapies. But here we have the BCR-ABL group, which is only 2%. So how is it possible to do a trial in this setting? Now we have effective therapies targeted to the BCR-ABL fusion gene in ALL, and this has been known about for over 20 years. So imatinib is now a generic drug, easily accessible. And it took 10 study groups, 5 years of recruitment, working together to test the addition of imatinib to standard therapy in this subtype of childhood ALL. And in this particular study, which involved groups from many, many countries and continents, here we have Hong Kong with Chi-Kong Lee, it was a very pragmatic trial design. They allowed each group to add the imatinib to their standard practice, but a key point was that they were all using similar approaches to identifying the biomarker for the presence of the BCR-ABL protein. But what you'll notice is, despite this big effort they weren't actually able to reach a statistically significant endpoint, although the 4-year disease-free survival in the good risk group was 10% better in the children with imatinib compared to those who did not have it. And you'll notice that in this era, which was, excuse me, 2004 to 2009, 81% had stem cell transplantation as a standard practice. Now, the same group continued. They could see the direction of travel, and also other groups, Japan, COG, were finding that imatinib was giving improved disease-free survival. And they went on and did a single-arm study, took another 5 years to recruit a similar number of patients, and were able to show, and also they altered the schedule of imatinib, learning from the studies conducted internationally in parallel. They decided to introduce the imatinib earlier and give it more continuously. And they achieved a much higher complete remission rate compared to the previous study, but no obvious impact on improving event-free survival and overall survival. But giving the imatinib in a more prolonged fashion did give more toxicity to the children. But in this setting, far fewer had stem cell transplantation, and they did notice a changing pattern of relapse, which could be much later if a child hadn't been transplanted. And so it raised further questions about the role of imatinib in maintenance. But what's been learnt from studies such as those is that consistent and prolonged multinational collaboration is essential, that trial design can take a pragmatic approach, providing core elements of biomarker selection of patient cohorts, therapeutic risk stratification, and treatment protocols are aligned. And that if you take account of similar results achieved by parallel large studies, this is probably more important to be certain that you've got a positive effect than the absolute p-values, because we know that these studies are very challenging from a statistical numerical fashion. So that was looking at introducing a biomarker upfront in first-line therapy. What about treatment of children with relapse, and those with refractory cancers, which are much smaller in number in childhood, but these are the children that traditionally go into early phase trials. And again, an excellent review article here published a year ago in Science. We've moved now from the era where entry into a study is based on disease diagnosis to one where it's based on tumor biology and the presence of a potentially predictive biomarker. And we're also moving to models where the introduction of the targeted therapy is happening much earlier in the disease course, that it's performed in all patients with recurrent disease, and you look at multiple sources of tumor DNA, which gets around some of the problems of intratumoral heterogeneity, and also gives these agents a greater chance of success than if you give them to children who've had multiple relapses. Now, this has changed the way we look at response rates, and I'm sure many of you in this audience will be familiar with this concept of a waterfall plot that shows the percentage reduction in a tumor size and the best response achieved, rather than, excuse me, a response at a fixed time point. And again, the response is according to the genotype. And here we see the example of shrinkage of low-grade glioma, which is known to have mutations in a gene called BRAF, which is a critical part of the MAP kinase signaling pathway, which is also disrupted in children with neurofibromatosis type 1. And many of these children have sight-threatening tumours and can be refractory to chemotherapy, and it's very undesirable to have to give them radiotherapy early on in life. So what you see here is that we now find, compared to traditional cytotoxics, that the best response, virtually all the children with the molecular abnormality will respond to an agent that's specifically targeted at the defect in the pathway in their tumour type. We also see outcome results presented as so-called swimmer plots, which show you what happened to the child, to each patient along a timeline, and the duration of therapy. And the key points here, and this again is the same children with low-grade glioma, they're on an oral therapy. Treatment may last several years. An outcome assessment needs to be holistic and focused on their quality of life as well as tumour control. Now, the other important concept, and BRAF mutations also follow this paradigm, is that the same mutation may be found in multiple cancers. And here we see the NTRK fusion cancers, which are found in a large range of adult and some pediatric cancers. And this is another important area of molecularly targeted therapy. So there's a very effective inhibitor of these activated NTRK genes by fusion. And here you see, again, a waterfall plot of best response in 2 childhood sarcomas. And you can see again that if they have the TRK fusion, everybody showed tumour shrinkage. And I would just like to point you to the fact that SciOp is now, through our knowledge portal on our website, offering CME accredited short courses that you can access online, and here's the link. And you can learn an awful lot more about NTRK inhibition at that site. But the key question is how to match the patient to the drug. The individual molecular entities are very rare in practice, and we need a new paradigm in trial design and in access to new therapies for children with cancer, because most of those studies I've shown you have been done in mostly in the United States and Europe and in high-income countries. So the first question, how to match the child to the drug? Well, precision medicine programs in pediatric oncology are building that capacity. And here you see a summary overview of these types of programs across North America, Europe, and in Australia. And the concept here is that all children with relapsed tumours or refractory tumours are eligible for inclusion, and they get genomic sequencing, molecular tumour boards, and then trying to direct children with specific molecular abnormalities in their tumour type to an appropriate clinical trial of an appropriate agent. And some of the drugs that they may be pointed to now are available as generics, maybe off trial, and sometimes it's possible to get them on a compassionate drug access program. Now, in Europe, Gilles Vassal and colleagues have built a platform called Accelerate, Innovation for Children and Adolescents with Cancer. And it brings together academia, from basic science through to clinical researchers, the parent and survivor voice at the table, very important for advocacy and informing trial design, industry, including their clinical leaders, researchers, and representatives from regulatory affairs, the regulatory bodies that actually approve drugs in various countries, and indeed any other stakeholders with an interest in pediatric oncology drug development. And the Accelerate group hold an annual congress now in its 9th year. It just took place in February. And they are building pediatric strategy forums, and they're picking them off disease type by disease type according to targeted agents. And what we wanted to avoid here is the fact that there might be 6 drug companies all making an inhibitor of the same pathway, and yet the children who might potentially benefit from these drugs and eligible for trials are very, very rare. And so they brought together the industry to decide what's the best formulation that's most easy for children to take in terms of its schedule, formulation, and let's think about building studies together so we can learn as quickly as possible. And you can see that they have had these various forums, and they often lead to manuscripts which are published, and they're about to do one on epigenetics. So to conclude about use of biomarker-driven clinical research, we have to remember that a biomarker, just as with any clinical test, cannot provide 100% specificity or predictive value. And the introduction of biomarkers and biological stratification into clinical pathways must be done in a carefully controlled way with holistic evaluation of impact on outcomes for patients. But properly powered testing requires international collaboration, standardized methodologies that are comparable, and sharing of genomic data at quite a detailed level. And it's absolutely essential that we involve patients and families from the start in research, design, and communication, because these are sensitive data, but these are also data that are going to help children with cancer now and in the future. So biology-driven drug development is opening up new possibilities of more effective cancer treatments. It's theoretically safer and should be more accessible, particularly around the world for oral therapies. But it does require detailed knowledge of tumor genomics, and the spectrum of mutations and genetic changes may vary by population. So it's very important that research is done in the populations where the drugs are to be used. So we definitely need to expand clinical trials and research to include more centres in non-high income countries. And I know that the AFOG initiative, spearheaded by Akira, is aiming to take South Asia countries in that direction. So I conclude with a message that we can all contribute to building the evidence base for best treatment for our patients. And that's why you're attending this Congress, and I hope you come away with lots of learning and enthusiasm to go home and do more research in your own centre and apply the latest knowledge. And thank you.